Through one of the indicated fire exits. Yeah, I can see those over there. This meeting's being broadcast live on our YouTube channel, and I'd like to welcome those who are watching online. And a recording of the meeting will be available on our channel after the meeting. And just to remind colleagues and myself, switch your microphone on when you're talking, but please switch it off when you're not, and that enables the camera to go to the right person. Can I also welcome members of the public who have joined us? It's really good to see you here. Thank you very much for coming. We'll be posting messages and photos on the Integrated Care System social media channels. If you don't want to be included in any photos, please just let one of the team know. Chris and Emily down here will be doing the posting. I'd like to remind people this is a meeting held in public of the board. It's not a public meeting. There are two questions that were notified. Actually, there are various questions that have been notified. We'll come to those questions from the members of the public later on the agenda. And when we do get to that question and answer session, we just ask people not to share any personal information or information relating to somebody else, just because the meeting's being recorded and transmitted. So the information will be in the public domain, and we don't want inadvertently to breach anybody's confidentiality. I also particularly want to thank Great Yarmouth Borough Council for hosting us here today and very generously allowing us to use the council chamber. We don't normally meet in quite such grand surroundings, and I'm very grateful to them for that hospitality. I also want to welcome and introduce two new members of the board who are starting today. Aliona Derrett, who's our fourth non-executive member of the board, and Aliona will chair our Patients and Communities Committee and our Quality and Safety Committee. And welcome to you, Aliona. There's more about you, of course, on our website. And I also want to welcome Stephen Coleman over there, who's the board's new partner member, one of two partner members from NHS Trusts and Foundation Trusts. And he particularly represents the mental health and community services sector from within the NHS. And Stephen is replacing Stuart Richardson. And I want to thank Stuart for his contribution as a partner member. He's stepped down from the board, as colleagues will understand, to focus on his role as Chief Executive of Norfolk and Suffolk NHS Foundation Trust. And of course, we'll continue to work very closely with Stuart in that role. Thank him for what he's done on the board, and welcome to Stephen. We have two new members of the ICB's executive management team joining us today. Ian Riley, welcome to you, our new Director for Digital and Data, and Emma Ojiaku. They're delighted to see you, our new Director of People. We have apologies from Sue Cook, one of our partner members, and Stephen Corse, our Finance Director. Jason Hollidge is here in place of Stephen. So welcome to Jason. Right, have I missed anything, Karen? No other apologies? Good. Minutes from the previous meeting. Is everybody happy with the minutes? Thank you. I don't think there are any matters arising that aren't on the agenda or in the reports. Declarations of interest, those are all, of course, recorded on the website. Anybody want to draw attention? No? Okay. Oh, sorry, yes, Karen.
New directors' declarations of interest will be on the website later today. They've just been appointed today, so they will be on later today. Thank you.
Perfect. Thank you. Chair's action log. Karen, can you just remind me, because I think there's been at least one chair's action since the last meeting.
There has, yes, thank you. There's been two chair's actions since the last meeting. One around adult eating disorders, which is on the log, and also the approval of a short stay recovery house project, again on the log. So there haven't been any further chair's actions since the last meeting.
Fine, thank you. I think everybody understands with meetings in public only being every 2 months, there are occasions when we just need to get contracts signed or decisions ratified, hence the need for chair's action. The general action log, that's all in your board pack. Any questions or comments on that? I think, again, it's either self-explanatory or covered on the agenda. And that brings us to Tracy's and my report. So the report from the chair and chief executive. I just wanted to mention two things that have happened since we prepared and circulated that report. One, of course, is the autumn statement. So the autumn statement, the mini budget in effect that was announced in the House last Thursday, announced a significant increase in the NHS budget of about £3.3 billion for each of the next 2 years. And Amanda Pritchard, the chief executive of NHS England, who briefed all chairs and CEOs on this last night, has said publicly, you've probably seen it, that she believes that should be enough to enable the NHS to meet its priority commitments. There are obviously uncertainties. We don't know what the winter COVID and flu season will be like. We're obviously all going on the new assumptions announced in the autumn statement about inflation. That is now, I think, we're very pleased to hear that that is now covered in this uplift. And there is also a significant uplift over the next couple of years in funding for social care, some of it coming through the Better Care Fund. So Tracy might want to add to that in a moment. And then the other thing that you may have noticed is that in the autumn statement, the Chancellor announced that he had asked me to do a high-level review of integrated care systems for the Health Secretary and himself. This is an independent review that I will be doing with the help of everybody in integrated care systems, local government, the NHS, the voluntary sector, and many other groups who is willing to help. And it's really, I think, a very strong vote of confidence in integrated care systems. And that both the Chancellor and the Health Secretary have made it very clear they want integrated care systems to work and to succeed. And they recognise that in order to do that, we need to get the right balance between autonomy for local systems so that local people can make decisions and solve problems together, and accountability, both locally and nationally. We'll publish terms of reference as soon as possible, but it's an exciting opportunity, and I think one where our experience here in Norfolk and Waveney, as well as in all the other systems around the country, can contribute very directly to shaping the policy and regulatory environment within which we work. So I'm pleased about that. It will play havoc with the diary, but of course I will not in any way reduce my commitment to our work here in Norfolk and Waveney, because that's what matters most. Tracy, do you want to add anything to our report?
Thank you, Patricia. So I think one of the things I wanted to clarify, because the autumn statement happened after we wrote this report, is that there are two tranches of winter funding. So the first tranche, which is in our report, which is the £11.7 million, we found out about back in September, and that is focused on buying more beds for the winter. So there's 233 additional beds, the majority of which are now open for the public. So the public might think, quite reasonably, in that case, why do we still have lots of ambulances sitting outside our 3 hospitals? And we know that it has been really, really difficult over the past few weeks and months. And part of the reason for that is that we are only getting now back to the position that we were in last winter when we had to buy additional beds. You'll remember that last January we were in critical incident and in a very similar position. So what invariably happens is that we are given additional money in winter to buy additional beds, and we have to find out each year if we will get the additional funding. And that gets us back up to a similar position in previous years. I think there are 2 good things about what's happened at the end of last week with the autumn statement and the announcement. And the first thing is talking about winter funding now becoming recurrent. And what that means is that we can plan over the coming years rather than having to wait to find out if we get additional money. And that will help our social care providers plan as well, and plan in terms of their workforce, rather than everybody having to rush around to put these things in place as and when we need them every winter. The second thing is we do now have an additional tranche of money, which is a share of the 500 million that you may have heard the government talk about in recent weeks. In our system, we've got just over £10 million, and that's shared between the NHS and social care. And it's really focused on what we in healthcare call Pathway 1, which is essentially when people are leaving hospital, they need some sort of domiciliary care and support in their own homes. So we don't have an answer to how we're spending that money yet, because it was only announced at the end of last week. But what I would say is that this is very much a systems response in working together through health and social care, third sector, and also in our places and localities as well, to try and work out what will help us move the flow through our system and keep people safe through winter. I also just wanted to reflect on, I know it's in the papers, but the carer's passport. And the reason for that is we did talk about that in the July meeting, and we were challenged as a system why we didn't have it and could we launch that. And I'm really pleased to say that in 2 days' time, we will be launching across our system, across all the trusts, the carer's passport, which will support a phenomenal 108,000 carers in our system, 20,000 of which are young carers. So to give those people the help and support they need is very important to us. And I'm really pleased that we listened and we've implemented that. And then the final thing is a point of order. We have done a little bit of a reshuffle of responsibilities in our team, and Stephen Course, who is the finance director, has been asked to take on the position of emergency accountable officer, and we need the board to ratify that decision, please.
Right. Can we just take that last point first? So is the board content to appoint Stephen as our emergency and resilience officer? Right, that's all agreed. Thank you very much. Any comments or questions on Tracy's and my report? Thanks. And apologies, because there will be some people who won't know all members of the board. Would everybody just introduce themselves and explain what they do on the board just the first time you speak?
Okay, thanks. I'm Cathy Armour. I'm the non-executive member and chair of the Remuneration, People and Culture Committee. Thanks. So, Tracy, I was really pleased to see the Carers Identity Passport launch, but I was really conscious that when we had the presentation, if you remember, that there was no feedback that had been captured, and I wondered what the process was going to be to capture feedback from how it's working, and will there be like a formal review process in place? I know it's not even launched yet, but I think it's really important to have those in place and and as part of the whole launch, really. Thanks.
That's a really good point, Cathy. Thank you. And yes, we do have review points and evaluation built into the programme because, as you say, just launching something is half the battle. We need to make sure it works. And the only way of working is testing it and feeding that back. So that is part of the programme. Yeah, James.
Thank you. James Bullion, the local authority partner member. I just wanted to welcome alongside within the ICB the additional funding for social care, but also just to acknowledge that as part of the national announcements that the reform of social care was delayed by 2 years, and in fact for some of the population that will mean the means test that they were expecting to change will change in 2 years' time. And the money associated with that change for reform is now to be repurposed within local government to deal with things like social care backlogs. And so that's part of the change alongside the new money for discharge. And I think it's important for the ICB to understand that part of the agenda as well.
Yeah, thank you very much, James. That's very helpful. Bill.
Thank you, Chair. Bill Borrett, and I chair the Integrated Care Partnership. I just really wanted to welcome your announcement about the review that the Secretary of State has asked for me, because I think it's been one of the frustrations of the fledgling systems, the lack of clarity about the role of NHSE within the partner organisations that form part of the role of the ICB. So to have someone from the home team, as it were, writing a report for the Minister, I think is fantastic, and it fills me with hope. I really do think here we have a project where we can really make some difference for the people we serve in Norfolk and Waveney, and I look forward to your report making that all clear to the Minister. So congratulations.
I look forward very much to your contributions and input, Bill, and many others to the report. Thank you. I think in that case, we can just note and receive that report. And we now come to what I think is, well, I hope will be a really important, it will certainly be a very regular feature of these meetings, which is really to take some time to reflect on and learn from the experience of people receiving our services, our local communities, and our staff. So I'm going to turn to Tricia to Tricia, introduce yourself and then introduce this item, please.
Thank you, Patricia. So my name's Tricia Dorsey, and I'm the Chief Nurse for the ICB here in Norfolk and Waveney. So I'm very pleased to be able to bring to the board today another case from learning from people, staff and communities. I can't believe it's my third board. And this opportunity to actually bring those true life stories to the board is evolving. And I think that the video that we're going to see today is going to be a very interesting opportunity for us to be in touch with what is actually happening within Norfolk and Waveney. This case actually was brought to our attention when Dr. Frankie Swords and I went and visited at NCHC, which was a fantastic opportunity to see community delivery. And we had the opportunity of speaking to one of the advanced care practitioners who was extremely professional and extremely passionate about the importance of the delivery of safe and quality care. And as a result of that conversation, she took us into a case. We have had the opportunity to speak with family members. And at that point, I'd just like to hand over to our colleagues in comms. And following on from this video, what I'm hoping for, Patricia, is a reflection from the board. Thank you.
Hello, my name is Heather Simons. I'm the lead advanced clinical practitioner for NCHC in Norfolk and Waveney. I'm talking through a patient story today that I've been raising to anybody who will listen, because I think it's a really valuable story around how we work as a system, how as individual organisations we can make things better and more seamless for the patient. So this particular lady, she's 93, she was living at home in sheltered accommodation. Daughter is a carer and was aware that mum had been deteriorating. There'd been contact through GP throughout September, daughter escalating that mum's not so well, had had a number of home visits, had had some blood tests, etc. And it escalated to a point where daughter telephoned 999. Through some joint working we're currently doing for admission avoidance with the ambulance service, I ended up discussing this lady with the advanced paramedic in the control room on the day and agreed that I would explore that a little bit more. So I gave the daughter a telephone call, had a bit of a chat with her, understood a bit more about what was going on, and then stood down the ambulance and said that I would go and visit and see what we could do and see what mum needed. From the conversation that I had with the daughter, I felt that she didn't really need an acute admission, but was mindful that until you get eyes on, it's quite a difficult judgment to make. And in the back of my head, I'd been thinking about maybe a community bed if she needed sort of more support than we could get her at home. So that was my backup plan. Went to see mum, and she was extremely frail, 93, quite weak, had been declining over a period of months, reduced intake, but very non-specifically. So we did a really good full-on review, reviewed all of her past medical history, reviewed all of her medicines. So she was extremely hypotensive, and one of the symptoms that she'd reported with the 999 call was dizziness. But she was on multiple antihypertensives. She'd been on a blood thinner long term without any tummy protection. They had talked about rectal bleeding. So we built a picture, and we had a really good conversation with daughter present as well. And we talked about what would be appropriate in terms of escalation, investigations. We talked about resuscitation. There was no respect conversation previously been had. And through all of the discussion, we came up with a plan of actually, she didn't want to go into an acute hospital and be pulled around. She was very clear in saying that she'd had a great life, and she, felt that she was naturally declining, and we talked about not over medicalising that. So I left a respect form in the home that was a clear plan of, happy for care at home, happy for support at home and treatment at home, but not for invasive investigations and not for escalation to acute hospitals, that community beds would be the ceiling of her care. So then it was, what should we do now? She was struggling at home, and we looked at care packages, what we could do, what next steps were. And we came up with a lovely plan whereby actually she was willing to self-fund to go into the residential care home that her daughter works at. Daughter had spoken to the manager, and manager was willing to start all the assessments, and everything was happy with the plan. So we felt we had a great plan. We put in some bridging care until such a time as we were able to get her in. This was a Friday afternoon, so obviously nothing was going to happen over the weekend. So bridging care and community, OT and physio. I was unable to prescribe anticipatory medication because previously somebody had documented that she had a particular allergy that prevented me prescribing opiates. So I needed to task the GP to do that, which they then did. So we were on board with a clear, not for escalation plan. Let's keep her at home until we can move her to this care home where she'll see more of her daughter than she currently did, and daughter could still attend work. So that plan was in place. There was a delay. I've chatted with social services since and talked about whether or not, given that she was self-funding, could we not have gone through that process a bit quicker to get her in? But the process is complicated in terms of making sure that if funds run out, then people can still pay for it, etc. And they felt that needed to be in place, even though I was clearly saying this woman was in the last weeks of life and that the daughter had the ability to evidence that the funds were available. Whilst all this was happening, the lady had night sits in because she was needing to get up and go to the loo, and she wasn't safe to mobilise on her own. Sadly, one of those night sits, several nights in, the carer went in to check on her and found that she had a further rectal bleed, and quite a significant one, and telephoned 999, which, on a night shift, you're on your own. It's completely understandable why somebody would call 999. Also called the daughter. The daughter turned up and said, well, we've got this plan. Can we do something different? She was sadly conveyed to the acute hospital. And then the following morning, the daughter contacted me and just said, oh, Heather, she's gone to hospital. And we had a big chat about it and, what we should do next. And she said she just didn't want to be there. This wasn't supposed to happen. What can we do? So I communicated with the acute trust had a good conversation with the doctors and talked about her escalation plan and that this wasn't what she wanted. And the doctor was in agreement and said, OK, do you want her? Can you take her? I had arranged a bed in one of our community hospitals, which we managed to transfer her to the same day. And sadly, she died a couple of days later. And the story for me, all the way from primary care through ambulance processes, through social services processes, through our own processes around we weren't able to fast track because she didn't have a definitive diagnosis other than frailty and severe, advancing age. So we just kept getting blockers around fast tracking, issues with the acute trust in terms of them giving her quite invasive intervention. She was having IV antibiotics, IV fluid, CT scans, all of the things that she had said she didn't want because she had then been conveyed in. So as a system, it feels like there's so much learning, so many opportunities to have made this a much more comfortable and seamless process. In terms of picking out those issues, I think that we've already moved on a lot. We're working really, really closely with the ambulance service. We're feeding back. This particular example was fed back to say, was that a junior crew? Is there something that we can do? Can we share respect training? And I've started conversations with CCG about how we try and link up with primary care, because unfortunately this lady had been seen quite a few times through September, but the meds reviews and the respect form, etc., hadn't been put in place. So I find it a sad story, but it's also a really powerful one to demonstrate exactly where we're going wrong as a whole system and how we can improve.
It was hard. It was difficult. Mum, in the end, she stopped eating, stopped drinking, and I phoned the doctors, and that was just health assistants coming out, and they sort of just said, well, that was just general deterioration. But I just felt that Mum was really in a bad place. I don't think I knew that she was seriously ill. I've done care 30 years of my life, and I've looked after the elderly people. But when it's your mother and you know that there's something drastically wrong, I just felt that, no, they didn't follow up what was actually wrong with her. I don't think that you could have done really anything more than what you did do. But in the end, what you tried to do with the syringe drivers being in place, because Mum was obviously on end of life, and it would have helped her. But then in the end, she still got taken to hospital, and then she was in A&E for 17 hours. She was then taken on to an acute ward where we eventually got to see her, and she had just totally not my mum anymore. She shouldn't have been taken to hospital. But Mum went, and then it was so wrong because she 17 hours in A&E for a 93-year-old who had a massive bleed was just not the best place for her to be. Exactly. Yeah. I mean, I had 2 phone calls, once after she died and the second time after she died. And I had to tell him, well, I'm sorry, Mum's passed away. And when Birmingham were willing to take Mum and everything was in place, they even had the hospital bed there. And then it was too late because Mum was, too ill in the end to get there because they just took too long. Well, obviously, myself, I cared for Mum as much as I could. And then when I called the ambulance, and then Heather came in and said, well, we, maybe help not Mum going into hospital. and she was absolutely brilliant. She was so good, absolutely brilliant. But I still think that when Mum had all the syringe drives and everything in a home to stop her going into hospital, why did they take her? I even sure the ambulance drivers, the syringe drivers, and Heather did say, well, why did they take her? You know, they could have just cleaned her up, you know, from the bleed and put the syringe drivers in, but they didn't. They just took her. And then as soon as Mum went to hospital, that's when I lost her, because she was just out of it. But I do think there needs to be more communication between the primary care trust with Heather and the ambulance drivers, maybe. I don't know. This is what made Mum go, I think. I would love to look after her at home, love to, but they took her away and she died in Dereham Hospital when I couldn't be there for her.
Oh, Tricia, thank you. That was a very, very powerful piece of sharing of experience. And, you know, I think all of us would want to say to Janine how sorry we are that, you know, she and her mum didn't have the death that they had all planned and would have been possible. And thank you also to Heather, who just described, I think, so brilliantly the way a community nurse can work with a family to try and put exactly the right thing in place around the individual patient and the family. And in this case, for reasons that I think Heather and Janine both identified very clearly, it didn't work. But very powerful indeed, and a sense of some learning started, but still more to come. But let's take comments and reflections or questions on that from the board. Yeah, Tracy.
Can I just say a huge thank you to Janine for doing that, because it's really difficult. I've worked with a lot of families who've done that, and it's a real gift to us to be able to see this and talk about it, but it's very hard on the families. So I just wanted to reflect that and say thank you. I have a background in palliative and end-of-life care. So what I'm saying is not reflective just of here, it's more societal and the whole country, which is that we seem to be quite good at end-of-life care for conditions like cancer, and maybe some other things now that we're starting to learn about a bit more, like heart failure and COPD and MND, for example. But when it comes to frailty, people who die of frailty or old age, which is probably how most of us would like to die, if we're honest, we don't seem to think about end-of-life care or palliative care. And even, you know, we often used to talk about in palliative care the fact that you can't, in England anyway, put old age down on a death certificate. You have to have a reason why somebody's died. And I think that part of the learning here, but also nationally, is that we really need to think about the fact that a good chunk of our population do die of frailty and old age, and they deserve end-of-life care and palliative care. And that would include physical symptom control, but also the mental side as well, being prepared. So the discussions around advanced care planning, discussions with family members, it's not just about planning for what you want at end of life, although that should be in place, probably should have been in place earlier actually, and we need to make sure all parts of the system feed into that and understand that and act appropriately. But it's also people might just want to have conversations about their faith. They might want to talk about unresolved issues with their family. We have all of these things in place if you have cancer, but we don't think about them when people are dying of frailty. And it is the one sure thing in life that if you don't die of a particular condition, you're going to die of frailty in old age. So if we learn one thing from this, and we are talking about frailty pathways and doing more to support people in their own homes, we need to make sure that we take that all the way through to end of life and beyond. Thank you.
Good. Thank you very much indeed, Tracy. And I realise it might just be helpful. I think it was what Heather was saying, and she talked about respect. And some colleagues may not be aware, respect is the, if you like, end of life sort of conversation and record of intentions and wants that we put in place and actually launched just before COVID. Very much, I think, all parts of the system working together on it. It was really welcomed, I know, by a number of patient groups. And in this case, it was in place, though, as Tracy suggested, possibly not quite sufficiently early. Anyway, other comments, please? Yes, James.
Thank you. Thanks, Patricia. And I really would absolutely pay tribute to that really powerful experience there. And personally, very sorry for the experience that both people have had, actually. And it does bring it home to you, doesn't it? The need for something in everyone's home, particularly at night, it seems to me, that will drive professional behaviour in a way that does respect people's wishes. And so often it's very resonant for me in situations I see in social care, actually resonant in my own personal situation where my mother died in Lewisham. Very similar circumstances, actually. And there is something about what do you do at the decision-making point about whether to convey somebody to hospital. What is there to counter that right there and then in the professional behaviour? So I think some work on that and obviously using respect and I think, as Tracy says, formalising the frailty work in Norfolk and Waveney as a pathway, I think will be quite a powerful thing to do. We also know them from research and from engagement with community groups that the word frailty is not particularly liked amongst older people. And Age UK have done a brilliant report about this, about finding another way of expressing this almost dying by wearing out sort of experience that many of us will have that isn't called frailty, because we get trapped into, I think, a professional jargon when we use that word, really. So, but I having said that, I do think it's an area where we should join up the pathways and have a plan for everybody. And it's not beyond our wit to do that, and that should be at the heart of our integration, it seems to me. Thank you.
Thank you, James. Yes, Frankie.
Thank you. Frankie Sawes, Medical Director of the ICB. Changing tack slightly, I just wanted to highlight that the work that Heather and others is doing is, I think, a really wonderful example of what we can achieve together as a system. So if you will recall, an ambulance was called, but an ambulance was not conveyed. A conversation was had through our virtual room, which we have in place, where patients who've phoned for an ambulance and have been categorised as they need it, but not this moment, not the most urgent, category 1 or 2, the slightly less urgent. Actually, we now have the facility to have a conversation with a team of multiple different professionals to say, actually, what's best for this patient? Maybe waiting for an ambulance is not the best thing. And actually, by working with our community providers in particular, this is a very new response, and actually sending an advanced care practitioner, which is in this case, a nurse who's highly qualified, able to prescribe, able to do tests, able to interpret them, actually to go and visit the patient in her home. And in other cases, we can send an occupational therapist with a hoist and with a frame in the back of the car if that's what's needed. We're doing lots and lots of rather imaginative things now to try and prevent that call for an ambulance, because as we saw in this case, really tragically, actually a hospital is not the right place to be in so many cases.
Absolutely. And we know again from a great deal of national as well as local research and just asking people, most people do not wish to die in a hospital. They want to die in their own home, if possible with their family there. Yes, John.
Thank you. John Barber, Acute Hospitals Partner Member. I want to thank Tricia for bringing that patient experience or that experience to us, because it is very powerful. I just want to concur with what Tracy said and what James has said. I certainly concur with the idea that we shouldn't call it frailty, whether we call it older people's medicine or whatever. But there's no point listening to an experience like that without taking away a real clear action. And I would like us as a board to develop a single approach across Norfolk and Waveney on how we're going to tackle older people's medicine. Tracy's absolutely right. You know, we've got pathways, clear pathways, things like people have got cancer, but we don't have it for this type of way of dying, and we need to support people. So incredibly important lesson we've learned today, but let's now do something about it.
Absolutely, and that's why we brought it. Hilary.
Thanks. Oh, sorry. Thanks, Patricia. I listened with a bit of sadness, I have to say, because it's a slightly familiar story to me where people have done all sorts of great work in talking to patients and families, working out what they want, setting things up so they're really sorted out, and then something goes wrong at the last minute and somebody gets admitted. So as Frankie says, it's great that all that work was done and she was kept at home. It's just then how do we take that a step further, and how do we have that support for somebody when it goes wrong in the middle of the night, which is invariably what happens. The plan is in place, something goes wrong, usually 2 or 3 in the morning, and then somebody gets admitted into hospital when it's nobody's wish for them to be there. So I think we almost need to take that a step further on. And a question really, or my lack of knowledge really is why couldn't she go into that bed if she was self-funding? If the bed was there and the money was there and that's what they wanted, do we need to tidy up our processes to smooth that pathway so that she could have just kind of bypassed that whole section of the story and gone straight into that bed?
Yeah. Thank you very much, Hilary, because I wondered about that, because there was the middle of the night crisis ambulance, which is very common, but there was the earlier piece of the story, self-funding, bed available in the home where her daughter worked. But that was held up because, if Heather was right, because of this need for social care to establish that if her funding ran out, what would they be? What bill would they then have to pick up? Even though we were only talking about a couple of weeks. So, James, I don't know whether you want to add anything on that at this point, but I think it's a really important piece to bottom out in the learning we do from this.
Yeah, it's unfathomable to me, actually, why that would have occurred in that particular situation, really. It's a common sense conversation about, well, how long are you going to need this facility for? And therefore, if it's not very long, then your money's unlikely to run out. I mean, it is ironic that a piece of action that's designed to protect people, in other words, don't go somewhere that you can't afford or that you then have to move from, has turned into a procedure that's a blockage for someone willing to express their own agency and control. So it is frustrating. It's something I'll go and ask the question, as it were, but it shouldn't be a block. It should be just a small part of the process. It needs to be there, but it shouldn't be a problem.
And as you say, common sense should enable a couple of people to sort it out in a very brief telephone conversation, one would have thought. Any other? Yes, please, Aliona.
Alona, the non-executive member. Just to add up to all of this about future learning, when it's an emergency, even if people share their views and wishes, sometimes we forget about what was being said where it's written. So when we think about shared records, strategy and so on, we really need to think about incorporating that into it. So it doesn't matter who comes to rescue somebody, they can access that information. Thank you.
It's a very important point, that, Aliona, because of course, just pre-COVID, we'd done this really wonderful piece of work, which enables the paramedic in the ambulance to have direct access to the GP records on that individual. So, Andrew, would you just pick up, Mr. Digital, Andrew and Ian, you just pick up, if you would, this issue about making sure that where there's a respect form or something relevant, that is part of the ambulance view in a 999 situation.
Yeah, hi, I'm Andrew Palmer, Director of Performance Transformation and Strategy. So I think for me, the theme there is choice, and it's people's wishes, isn't it? So I suspect there's also a perspective there about governance. So if an ambulance crew comes on scene and they find somebody with a major bleed, they've got to do something about that because they're there. And I think that was what came across to me from the stories, that if we'd recorded somebody's wishes, somehow we'd not shared that. And I think that's the trick. And I think we'll see a bit later on the agenda that through the digital plan, that's something that we hope, I think, to do some pretty amazing stuff with. So if at the end of your life you can't be listened to, then when can you?
Thank you. And Tricia, thank you again for bringing Heather and Janine into the meeting in this way. Really powerful. I'm very conscious of time, and I think obviously what we would look to you and Tracy to do is, team, let us have a report on this at our next meeting about where we can take this learning. Is there anything you wanted to say quickly?
Just the richness of the conversation and the intent to work differently as a result of the story that we've heard from Heather and Janine today is enough. Thank you.
Thank you very much indeed. So we'll move on to item 8, which is the Integrated Care Partnership Strategy that, as I think everyone is aware, and it's included in the board pack, we agreed at the Integrated Care Partnership and Health and Wellbeing Board very recently. James, do you want to say just a few words about this?
Yes, so as you say, Chair, this plan is for the system as a whole to join together really the pre-existing strategic intentions of the Health and Wellbeing Board with the strategy of the Integrated Care Partnership. And for the uninitiated and the governance junkies, this is a way of us bringing under a single paper the ambitions of the broader Health and Wellbeing Partnership called the Integrated Care Partnership and this board, which is overseeing the NHS. And so the paper describes a continuity really between the Health and Wellbeing Board and this Integrated Care Board, with a few priorities that are described in the paper, and is seeking endorsement of this board for adoption. I suppose I would say it's really the start of our journey rather than, it's a document clearly with guiding priorities for us, but it's not, as it were, to be a static set of proposals which we don't revisit. It's expected that both in the Health and Wellbeing partnerships and this board and in the committees and groups that we work in to be taken as our sort of North Star and direction. And clearly between now and next spring, when we will have finalised all of our strategic paperwork for both the board and the partnership, we'll be revisiting and refining the strategy as we go.
Good. Thank you very much, James. Bill, I was going to turn to you to say a bit on this.
Thank you very much, Chair. It was really heartening to have unanimous support for the strategy from all of the partner members of the ICS. Now, that obviously includes the voluntary sector, all of the district councils, Suffolk County Council as well, and the private, the representative bodies for the private providers that run care homes, and even some of the provider members from the NHS, for example, the Chief Executive of the NNN sits on the partnership board as well. So to have that sort of unanimity around the broad strategy was really positive, and I think really represents how committed all the partners of the ICS are to changing the way that we work as a system. I mean, I think it's the first time this has ever happened. And I think that, the key priorities within the strategy, which are quite high level, because it's not designed to be an operational plan for all the different bits. It's an opportunity for all of the constituent parts of the ICS to do their own strategies, giving regard to the key issues in this strategy, and then within their organisations, the actual action plans of your different teams or underneath that. So there is a hierarchy here. So it isn't that this strategy is about telling all the different organisations how they must be working in a way that we might have felt perhaps that guidance coming down from above in other places has worked. This is much more about, these are the broad key objectives of the system, and it's up to you as professionals in your area to then design and deliver a strategy, and then your action plans after that underneath it. So I recommend it to the board. One of the things that we agreed at the ICP is it would go to all the partner members of the ICS to take through their governance. So all of the organisations that I've mentioned in the introduction will all be doing this as well. Thank you very much.
Thank you very much indeed, Bill. And I think, hopefully everyone's had a chance to read it. It's a really excellent piece of work. I think it sets out our ambition, our commitment to a common purpose. And of course, we as NHS Norfolk and Waveney have a statutory duty, quite rightly, to, I think the phrasing is, take account of it as we develop our own plans. And that's exactly, of course, what we are doing. So is the board content to endorse that? Thank you all very much indeed. Excellent. Now, on to the winter plan. Tracy referenced this earlier on in relation to our report. Now, this is a really major piece of work. You've had the background paper, but I'm going to hand over to Mark just to, if you would briefly introduce it. Thank you.
Thank you, Patricia. And I'm Mark Burgess. I'm the Director of Patients and Communities. So the report I'll take as read, but I'm quite keen to pull out a few kind of key items. Tracy highlighted already, we're very pleased to see that we have some funding made available this year and hopefully beyond to enable us to plan more effectively and better for winter going forward, which is always welcome. But actually, just a key thing, a couple of points to kind of highlight at the start. First of all, winter planning is something that we do every year. I've been around too long to remember how many times I've done this, but actually the last couple of years have felt different in that typically we have a slight lull in the summer period and then we ramp up again in winter. We haven't seen that for the last couple of years, and I don't believe it's just COVID either. So that's put real pressure on our providers, on our teams, on our people working across health and care, and that's a really important factor that we're considering this year. The second point is around winter planning. We're typically talking about urgent and emergency care. That's what people generally think of, and that then often leads to ambulances and hospitals. But I'm keen to stress, and I hope hopefully the report does, that actually it's much more than that. It's demand in primary care, demand on community services, mental health services, and social care really does ramp up at this time of year typically as well. The report here is brought today to update members of some of the work that's being taken and planned over the winter period, and I thank all of our providers, colleagues and teams who have worked really hard to make sure that we have strong plans this winter, and I think we do have good plans going into this winter period, but we must acknowledge we are all forecasting a challenge few months ahead, and I don't think any of us can ignore that. So it's brought here for information and hopefully asking members to endorse the plan and the approach. So a couple of last key points from me. It is really important. We heard on the patient story today about how it is best when we work together, and it is least effective when we don't communicate well and work together. This plan that is brought here today has been worked up across partners jointly between health and care, providers, commissioners, and I think that's one of the real strengths of this. And it's not just the statutory services. We've worked with voluntary sector partners to say, what can we do? And also to listen and feed into this plan as well. I think we can do that better in years to come as well. But that's a really crucial element to this. We cannot ignore where society is at the moment, our patients, our communities, the cost of living pressures. Supporting the most vulnerable in our society is a key part of our plan this year, and I think that will be something. This isn't just a we do once and then run on with it. This is something that we need to continually be dynamic and change as the next few months come forward. Some real challenges and risks highlighted in the paper. I won't dwell on them now because I'm better done in discussion, I think. But workforce is highlighted as one of the real risks to us. Capacity more generally, and flow through our system, and supporting patients to go home should they need to go into hospital is one of the real challenges the report highlights. But if I perhaps pause there, I'm sure discussion will pick up many of the other points. Thanks, Patricia.
Thank you very much indeed, Mark. Tracy, do you want to add anything at this point, or we can just throw it open?
No, happy to go straight into discussion.
Okay, great. So questions and comments from colleagues. Hein.
Thank you. Hein van der Wildenburg, non-executive member chairing the Finance Committee. Thanks, Mark and colleagues, for an excellent paper. I've witnessed a number of your winter plan report outs over the years, and I think I was particularly struck the partnership working across the system. So the working with the social care sector and voluntary sector, community healthcare, etc. So I think it's an excellent plan. I'll warmly support it. I have a particular question about the System Control Center. Could you say a bit more what it is? Is it a physical place? Is it virtual? Who sits there? Thank you.
Thank you, Hein. And it was one of the must-dos, but actually our police report was one of our plans before it came as a must-do. So the system, it's a virtual space at this point in time, but we are considering, do we need to have a physical room as part of that dynamic planning? We have appointed a winter director this year, but in recognition actually that the stress and pressure on the teams, on individuals, is really intense at this point part of the year. So actually the appointment of a winter director, Marcus Bailey, at a very senior level to really lead us through this winter and coordinate across partners and systems is going to be key. So it's virtual at this point, but already working quite well, I believe. Thanks.
Can I just check, this is one winter control room for the whole system?
Absolutely, and with representatives from providers, regular gold calls at times of escalation and things of that nature. Yes, Patricia.
I mean, that's a really big step forward, I think, for the system. Let's take David and then John.
Great, thanks. I'm David Holt, one of the non-executives. Like Hein, I've sat through many winter plans and have sort of gone into them slightly with my eyes closed, thinking it looks great, and yet we've all sat here, we know what our current state of play is, we know what's facing us, and so risks come right to the forefront. And I suppose that the question I would ask of chair of the audit committee is just how confident are we around the sort of mitigating actions, particularly where we need coordinated approach, or we need to draw down resources from some of our partners in order to address these risks if they materialise. We've heard a very sad story today about what happens when people are under stress or data's not there. How confident are we around our mitigating actions on those risks? Because one thing is for sure is we all know we're going to need to call upon some of those, and just have we tested them? Have we really talked to our partners about the role they will need to play if some of those risks materialise?
Thank you, David. A difficult question to answer, and I might ask some of my clinical colleagues to come in on this as well, actually, because actually what we're planning here is how do we keep people safe over the winter period. In terms of our plans, I think we have strong plans. I think in terms of mitigating actions, I think we have good mitigating actions identified. But as I highlighted when I first spoke, it's workforce, people available, capacity. That's some of the real challenge that we have when we are needing to react. I think the other key point is I think we are able to react far quicker now when things escalate and deteriorate than we perhaps have managed to in previous years. And one of the things we're often commended by from regional colleagues is actually how the system works together at times of pressure. Just to relay a recent experience of on call, 3 of our acute hospitals really struggling, all of them, but perhaps one was struggling a bit more than others, and the others agreed to take a few more ambulances just to try and help. So in terms of mitigation, suboptimal decisions on many occasions, but actually that willingness to work and share and do the best we can to support patients is key. But I don't know if colleagues would like to come.
Thank you. Let me take John and then I'll come to Frankie.
Thank you, Chair. I think this is a really clear report, and I think what we should commend Mark and his team for is looking in every possible corner for where we can get additional capacity. In that report, there is a short paragraph which talks about working with housing associations and the capacity they've got with housing with care. I think this is a fantastic development in our approach to try and get all the actors in our play together. And I think the mere fact we're starting to bind in wider partners to give us the solution, I think is commendable. So I think this is a big step forward.
Thank you very much. Frankie, on that or other points as well.
Thank you. I just wanted to pick up on David's question actually around the risk. So as well as the 24 hours a day, 7 days a week resilience team, we have a drumbeat of daily system-wide meetings, and we have a weekly clinical meeting whereby the medical directors and the chief nurses, so that's myself and Trish for the ICB, but the medical director and chief nurse of all of our different organisations working across health, come together to share our risks and review them together, because we are all working under exceptional pressure. And sometimes it can feel like your risks are the only risks or the biggest or the worst. And what we try to avoid is a sort of top trumps of who's got it worst, and move rather to actually together, what are we most worried about? So what can we do specifically to mitigate those most important risks? And the most worrying risks for us as a system going into winter are patients waiting too long for an ambulance. And so by working together, as Mark says, we may not always be able to do everything we would like, but we will be able to do the very best between us and mitigating those risks in a really dynamic, supportive way.
Thank you very much indeed, Frankie. It's exactly, I think that and the wider work is a great example of why integrated care systems and integrated care boards are exactly the right way to go, because this was not happening previously. Yeah. Now, was it Emma? I thought, oh, right, Emma, then John, then Cathy.
Thank you, Patricia. Just from a voluntary sector, Emma Ratzer, Chair of VCSE Assembly. I just wanted to say from a voluntary sector point of view, the benefit of something like Mark's report, but also the strategy that James and Bill were talking about, was for the first time, it's really clear where we can help. And I think particularly around winter pressures, we often sit here thinking, well, I know I can help, but do I have to wait for a procurement exercise before I can put my white flag up and say, can I help? So I think one of the things that I will be doing is taking these reports and strategies back and talking to the sector about, this is really clear now what we can do to help. And so for that point of view, thank you.
That's right. So I wanted James Bullion, Chair of Primary Care Commission Committee and Local Government Partner. I wanted to acknowledge the work that Mark and the team have done, and I don't think we've faced a winter quite like this in terms of the confluence of things coming together. I wanted to, in addition to other people's points, point to the workforce resilience and well-being issues that are raised in the report at 231, because I think it feels important that organisations take a response to the well-being of their workforce. But I wonder over the winter how this board would take stock of the impact. We go into the winter, with strength and determination, but actually February, March, how will our workforce be feeling about the impact of winter on them and sickness levels? And so I do think it's a point, Mark, to note a stock take point at some point over the winter at this level would be really useful.
I was going to raise a similar point actually to James about resilience of people over the winter, which we'll obviously pick up as part of the People and Culture Committee. But also I wondered how the recruitment drive is going. I think it's on the back of buses as to come and work with us, and I just wondered, are we getting the response that we need from people to come and work in health and social care? Does anybody know? Yeah.
Emma, would you like to introduce yourself and comment on that, please?
So Emma Jarko, Director of People. I think the response is that we're taking quite a holistic view around our recruitment, because just as important as recruitment is also the retention of staff. And a really, really critical part of the retention of our teams is that, as we've discussed here, people are working, it's quite a challenging winter. People's resilience is low, etc., etc. So we are seeing success with our recruitment campaigns. We're actually meeting a lot of the targets that we set for ourselves in terms of bringing people in. The key focus area that we're doing alongside that is to keep them. So there's a huge amount of work we're doing around culture, around wellbeing as well, to make sure people are supported, particularly now during winter. And those joining us during winter, it's especially important to make sure that they're supported as they're working in quite challenged areas across organisations, as you can imagine.
Thank you very much, Emma. Right, any other comments or questions? Mark, is there anything? Oh, yes, one over there from Stephen.
Sorry, yeah, I just, because I've been Stephen Coleman, new non-partner member for community and mental health. I think there's a couple of bits to pull out that we need to really link to the autumn statement money that you mentioned, but also the way that we want to take this forward as an ICB. So I think there's just bits I would draw out. I think that bit about the voluntary sector and talking to people a lot earlier and actually embedding them in whatever we do around resilience, I think is really, really important. And that move to more recurrent money, I think we've got an opportunity to really do that planning now, not almost take the foot off the gas and keep that going, really push on it. I think the other thing to pull out of this is around place, and I think that's another area that we really need to focus on. What is a system response, as an ICB will do across all, but what's place's response, and how do we engage place in really driving forward, because that's where a lot of the change in our urgent care system will come from. And I think what this starts to do is it builds into an urgent care strategy, and we've got to see it that way, so not the one-off, we do it for winter and then we stop. I think we've just got to keep building on it now and really put some effort and emphasis behind it.
Emma, quick point.
Sorry, just a quick point. Just on the recruitment of staff, we just need to remember that there's a bit of a difference between NHS recruitment and recruitment that goes on in the voluntary sector. So if there's pay increases or holistic wellbeing that's going on within your NHS staff, that doesn't happen at VCSE level unless you increase the price of your contracts.
I just wondered, in view of the conversation on recruitment and retention, whether it would be sensible if the board had an update on the anchor programme work that's going on with the University of East Anglia, which is looking at how do we encourage people in Norfolk and Waveney to work in health and social care roles. How can we value staff? How can we think about voluntary sector and that broader conversation around workforce and retention?
That's very helpful, Tricia. And I would suggest Emma's been with us for, a week? 2 weeks, exactly. So I think perhaps executive team take that one away. And I think we can think about whether we come back to that in January or the meeting after that. But yes, I think that would be very helpful. And I don't think there are any other questions or comments, are there? Oh, I'm sorry, Hilary.
It's just a question for Mark, really. I'm assuming there'll be a patient engagement, public engagement piece that goes along with this around using, for example, community pharmacies and other corners, as somebody mentioned it, in the system that may be able to help us.
Absolutely, really good point. Yes, and it started just a few weeks ago as the phase one. I think the other really key point and part of this is around communicating with our staff, picking up on some of the other comments, and it's all well and good for some of us to know what's going on, but I think we need to do a better job this year perhaps than in previous years around trying to share what is exactly it is that is happening to try and not just support our patients, our communities, but also our staff, because I think that will be really critical, as colleagues have made the comments earlier.
Good. Well, look, Mark, thank you very much indeed. And through you, thank you to everybody who's been involved in this piece of work and is going to take it forward through the winter. And I think, as always, a sort of theme here is, while you are dealing with the daily and the weekly pressures, do it in the transformational way that then continues to build resilience in the system and reduce the kind of pressures or crisis we will face next winter or indeed next summer, because it's a kind of year-round issue, as you've all been saying. But I think really important work this, and absolutely part of our system-wide transformation. So thank you very much for that. Right, we now come to item 10. Now, this item, you'll remember, this relates to maternity and the East Kent report. We had a very helpful update from Tricia on maternity services in our system at our last meeting in September. But NHS England, for very understandable reasons, have asked all integrated care boards to just have an update on the East Kent report and be aware of the issues and the potential learning for all systems from it. So over to you, Tricia.
Thank you, Patricia. And I will keep it brief, even though it is an extremely important paper. So as Patricia's helpfully articulated, we brought a comprehensive paper around the LM&S and maternity to the last board. Then there was the publication of the East Kent report and the request to bring it to the board. I'll take the paper as read. I think for any of us that have actually read through the report, which I would strongly recommend board members to do so, it makes for very, very challenging reading. But it also gives an opportunity to us within Norfolk and Waveney through the LM&S to take assurance that we're really doing the best for those in receipt of maternity services. The key areas within the East Kent report focused on failures. So failure of team working, poor culture, a lack of compassionate and listening care, learning from safety incidents, and most importantly, and hence why the request for the ICB to receive the report, a lack of board oversight with regards to the quality metrics and the delivery of care. I would request today that the board members note the report and also endorse the recommendation for oversight into the LM&S, and also to ensure that when we have completed the delivery plan, which needs to be created by spring next year, that too will go to the LM&S board, but also to come back here, Patricia.
Just to translate, because I think we're all very conscious of NHS acronyms, I think we're talking here about the local maternity and neonatal system, otherwise known as the LM&S, but that's what we're talking about. Let's take any comments or questions, please, on this. Sorry, Frankie.
Thank you, and thank you, Tricia, for bringing such a helpful summary of this report. As you say, the Kirkup report makes pretty startling and upsetting reading, and there is clearly learning for every maternity unit in the country within this. Interestingly, just this week, there's been a publication of a national confidential inquiry, the MBRAS, that's Mothers and Babies Reducing Risk Through Audits and Confidential Inquiries across the UK. And that has just been published this week, looking at the rates of complications and indeed deaths of mothers and babies across the UK. And there is, unfortunately, as there often is, a league table, but just to highlight and give assurance to members of the board that none of the units in Norfolk and Waveney are in the lower quintile. But that's not to say we would rest on our laurels, because there's absolutely always more to do. And the culture of maternity units is absolutely vital to the safe team working to get the best for our mothers and babies.
Absolutely. And thank you for drawing our attention to that other report. I wonder if I could just make a point, which I think is relevant here, although it was prompted by looking at the next item and in particular, the local maternity and neonatal systems digital strategy. When I looked at that, of course, one of the things that leaps out is that we have 3 maternity digital strategies, which I'm glad to say look remarkably similar, one from each maternity unit, each of our 3 trusts. And then we have a 4th, which is the system-wide one. And it just seems to me that both on the maternity digital strategy, but actually more widely, there might be real benefit in bringing together some of the midwives, some of the consultants, obviously Frankie and Tricia, and our digital people, to look at this across the board. And I think building that culture of learning from each other, sharing risks and problems and solving them together might be very helpful, and it will have a particular benefit in the context of digital, which we'll come to in a moment. But I would like to make that suggestion. Frankie?
The 3 maternity digital strategies have all been overseen and led from within the local maternity and neonatal system. But of course, what we want is one, which is why we're very keen with Ian, Andrew and others in our bid to get a unified electronic patient record for patients and staff across the whole of Norfolk and Waveney, particularly the 3 acute trusts. And the maternity digital system is a key part of that. So the plan is to have one.
Good. Thank you. That's very helpful indeed. Right. So if we could at this point, we will note the East Kent report and the learnings from it. And also the fact that at the moment, on the basis of the nationally published data, we do not think we have those kinds of, certainly the data does not suggest that there are those kinds of problems within our 3 maternity units. I think that would be a fair summary. Yeah. Right, that brings us to item 11, digital transformation. So I'm handing over to Andrew and colleagues, I think, on that.
Chair, thank you. Ian will lead the conversation on the digital roadmap, and I believe we've got Tony, our digital project manager for maternity services, who's joined us to talk about the digital strategies. Patricia may wish to mention something on that as well. So if we just talk through, they're very large documents. It's 137 pages for those that have read it cover to cover like I have in proof in it. But I think if we can pick out key points, and then we'll have a discussion. So if I may pass to Ian, if that's okay.
Yes, thank you. And just, we've read it, so highlights.
Thank you, Chair. Ian Riley, I'm the new Digital Director for Norfolk and Waveney. So as Andrew said, there was 2 papers in the pack. One was a summary, which is slightly shorter at 12 pages. I think it does set out why digital is quite important and the ambition that we've got in Norfolk and Waveney with the digital strategy, how it underpins our main goals, where people can live a healthy life as possible, tell their story once and be the best place for health and care. I think crucially, the work on digital and improvements in digital can really help with ensuring people are safe, that we've got safe care and good quality of care, give our staff more time to care because they're not on paper, they're using modern systems, and really empower our patients through the use of digital. So that's all through the strategy. In terms of branding, I think you'll notice that we've used the Protect Now brand from our work on COVID, and we've settled on Connect Now. So that's quite key to the branding of this. There's been significant engagement through Andrew's help, with all of the partners, with patients and citizens of Norfolk and Waveney in developing it. And obviously the hard work, if it's approved today, starts as well with further engagement with our partners, and it is going through all the governance of all the local partners as well. There is a roadmap in there that shows the next steps for us, and we need to agree the financial plan, keep reviewing it if the clinical strategy changes, but really just get on with it now, I guess, and implement the strategy. So, but big thanks to Andrew and the team and all the partners who've contributed to the strategy. But I'll leave it there because I know we're short on time, but thank you, Chair.
Thank you very much indeed, Ian. Andrew, a huge amount of work has gone into this, and some of us around this table and many others, as you say, have been involved. So questions and comments, please. And yeah, let's take questions and comments, and then Tricia, if you want to add anything further on the maternity side, we can come to that. Kathy.
Thank you. So I was thinking about my parents when I was thinking about the care at home, providing more care at home with digital, and neither of them can use digital at all. And I thought, gosh, I'm going to have to move in if they have this. How will elderly people be able to cope with these innovations in their own homes? I think, even with education and training, they forget it instantly. So that's the bit that baffles me, really, because I think it's great, but it's almost, it's a generational thing, really. Thanks.
Kathy, that's a great question. I think the two parts of that answer. So the first is that we mustn't underestimate people. And I think if you can buy a book on Amazon, then you can use a health app. I think the other perspective that we need to look at is about the professionals. So when they're having those conversations with your family, as you mentioned, or with others, they will have access to all the information through the new electronic patient records, so that we don't have a repeat of the story that we heard earlier. So it'll make it easier for professionals. And of course, you won't have to sit in front of a really complicated system with lots of screens. The bit that patients will access through the portal will be very user-friendly, so more of an app-style approach. So I think my mum's watching, so I will say this for her benefit. She would not touch the internet. She didn't want to do it. She's now got a laptop. She shops online. She looks after her own care. She uses the NHS portal. So it can be done.
I think there's something really important here about, it comes back to personalised care and support, doesn't it? There are plenty of silver surfers, some of whom didn't think they were going to be silver surfers. There are also some, including those who've got cognitive decline, dementia, and so on, for whom it's simply not appropriate. But where the carer, in part thanks to our carer's identity passport, can actually do a great deal of that. And it might be much easier for the carer to do it online while having the conversation as well with the elderly person. So we need to remember that. We'll take James, then Emma, then Aliona, and then I think Tricia. Okay.
I wanted to welcome this, Patricia, from a local government partner perspective. We had a presentation to our corporate board in Norfolk County Council, taking us through the roadmap, and there are really clear opportunities for joining up across the system, for a shared infrastructure, lots of possibilities and lots of positivity, but also some realism, I think, about the distance to go and the number of years it will take us potentially, up to 6 years to get to an end point of complete perfection, as it were. My question was more about the resources and how the paper acknowledges the gap, doesn't it, between what we've got and where we need to get to. And so I just wondered what we as a system can do to, as it were, advocate for more resources on this. And thank you.
Right. I think, Andrew, it might be helpful, or Andrew and Ian, if you want to gather up the questions. You might want Jason to help on the finance one. We can come back to that. But hold that question and others, and we'll take them together. So Emma, Aliona, and then I want to take Bill, and then we might come back to the maternity issues. Emma.
Thank you. I suppose it's a similar flag to Kathy's, but what about, or how are we talking to, or what organisations are you talking to about the people who are not IT literate because they cannot afford broadband? I've got lots of young people, they're selling their phones to pay bills. We've got families who are disconnecting all of their IT because they're frightened to turn it on. So whilst they will recognise this as something that's really exciting, the practicalities are they just can't access it. And I'm just wondering how we're including that, because they would love this and they will see it as very ambitious and very exciting. And if I can do all my healthcare on an app, that's brilliant, because actually it means I don't have to engage with everyone in suits that make me very scared. But I've just sold my phone to pay for my kids' school lunches.
Yeah, thank you, Emma, for just reminding us of the sharp end of the cost of living crisis at the moment. Aliona.
Thank you. I'm a strong believer in can do and everything is possible, but there's reality. And I'll link back to Emma and Kathy's comment and your own slide with the title, What People in Community Said About Digital, the last little square in accessibility. And from my day job, I can confirm to you that there's many people who cannot access digital information. Example, we'll send you the appointment confirmation letter via email, and the answer is, please do, but I can't read it because I cannot see the screen. So people have visual impairment, cognitive decline problems, and so on. The list goes on. So please, my plea is, can we make sure that we have information available to people which is not just digitally driven? Thank you.
Thank you. I mean, the thing is, I think the general public think we're doing most of this already. So I think that we'll find that their expectations of our digital integration as a system are far greater than actually what. So we are playing catch up. You know, there's two parts to this report. There's how we all talk to each other, and then there is the issue around how people access us digitally. But the bit that which is I think the bulk of this report here is how we share information. And the protocols about who we're prepared to share it with and in what form, and are we using the right platforms, and do they talk to each other, is the bulk of this. This is the bit that we've really got to get on with as a system, and we can't hang about. And actually, the job is too difficult unless we get this done. So, you know, this should be a priority. Some of the internal stuff is that, you know, the information is critical, because to make the right decisions, I mean, in a timely way, is one of the things that we've heard, is the availability of information, and actually general information on the population at large, so that can help us plan services as well, to pull through, and also so that our staff aren't filling in endless forms, because the data can be pulled through from one into another in a timely thing. So it creates it saves time, and it makes people who are working in the system, who are compassionate people, spending less time dealing with sort of paperwork and demands, and more time dealing with the bits that they find most interesting, which is people. So it is a really important report. And, you know, going on to, I think, James's earlier thing about the money and the resources, I think this is one of the most important things that we can agree as a system, because it's the thing that's going to bind us all together and make us work as a system.
Endorse that wholeheartedly. Tricia.
So I will hand over maternity to Tony Geary, if that's okay. However, I just wanted to pick up on a couple of those themes. I think Bill is absolutely correct. The general public believe that we share information more readily than we do, so I have to endorse that. And I think it's really important that we consider that not one size fits all. So it's about any of these strategies, going from a health inequalities and an equality and quality impact position, I think will help with some of the concerns, quite rightly raised by lay members today. I'm just thinking, though, is there not the potential, perhaps in some of our surgeries or our libraries or warm spaces for this winter, to have the accessibility of a screen where people could go in if they are not able to source that equipment because of fear about electricity, etc. So I think this is a great opportunity, to building on the conversations we had earlier about the strengths of the ICS, to think about how we get around those potential blockages so that most people have access. I don't know, do you want to bring Tony in now, Patricia?
I'm absolutely going to do that. And Tony, forgive me for not spotting that you were with us earlier, but if you would just introduce yourself and then...
I don't know how this works. Have I switched it on or not?
You've switched it on, that's perfect.
Thank you. Hi, I'm Tony Geary. I'm the Programme Manager for the Local Maternity and Neonatal System, which is the LMNS. Do you want me to introduce the strategy as well and kind of talk?
Just briefly, if you would, because obviously people have read it.
Yeah, no, that's fine. So we've been tasked with ensuring that across our system, each of the trusts has a digital strategy that is aligned with their strategy. They're here today for ICB approval because that's part of what we've been asked to do, but actually really important. They are aligned to the wider strategy and we've been working with them on that. We know we've got a lot of work to do, but I think some of the really important things to recognise is that all of the trusts and the LMNS now have digital midwives and digital maternity teams that are helping to take this forward. The strategies give us a clear direction of travel and they're based on the What Good Looks Like framework. They are only for a year because the outcome of the electronic patient record is going to be critical to how we take our work forward and how we deliver that. As I've said, they align to the wider one. We do also have a digital gifting project that is working within our system, which is based in the libraries, and that is for people who can't have access to digital technology to enable them to actually be able to digitally engage with maternity services. We will monitor our strategies through our digital work stream and through the LMNS board, and those work streams and that board contain all of the partners in the maternity system that are critical to that. Thank you.
Tony, thank you very much indeed. Can I just ask a question around, this is around the digital maternity strategy, but what is it connects, as you were rightly saying, with the electronic patient record, which is really one of the biggest and most important transformationally enabling projects and investments that we need to be doing as a system over the next few years. But of course, putting in an electronic patient record is not about just putting in some IT. It is fundamentally about making sure that, particularly across our three acutes, this will be a single system, there's a commonality of approach, because you can't have a single electronic patient record if the three sets of consultants in maternity or any other speciality are working in different ways. So there's a whole piece of joining up around the clinical processes and so on that then shape how you install the electronic patient record. I don't think I've quite got the technical terminology right, but hopefully what I'm saying is clear. And Frankie, it would just be helpful, I think, to know from you, or indeed from Tricia in relation to maternity, or Tony, have we got that clinical joining up underway? And are we clear about the relationship with the acute hospitals group and the committees in common, who, of course, have a really important part to play in overseeing the clinical transformation and the electronic patient record?
Thank you, Patricia. So the short answer is yes. The longer answer is that the electronic patient record board actually sits directly underneath the committees in common. So we're talking gobbledygook a bit here, but the three hospitals, the three big hospitals in Norfolk, have a committee whereby the chief executives and the chairs meet regularly to make sure that they're all pulling in the same direction and pulling together. And as a part of that, they oversee various boards with us to a greater or lesser extent. Some things are just hospitals, some things are much more system-wide, to make sure that they're doing things together. And the Electronic Programme Record Board is one of those joint projects. I sit on that board in my current job as the medical director of the ICB, but I used to sit on it as the medical director of one of the acute hospitals. And I used to chair the Clinical Design Authority, which is one of the work streams, which has now been taken over by my colleague, Mr. Ed Prosser-Snelling, who's an obstetrician from the Norfolk and Norwich. So you can see things are joining up quite nicely there. And we have a network, it's called the CXIO network. So that's Chief X for whatever it is, nurse, doctor, physiotherapist, operation lead, I for information, O for Chief Information Officers. And they have a network that works really, really closely together, because bringing in digital isn't just transforming your paper onto an electronic form. That would be a colossal waste of money. It is transforming the way you work. So, for example, bringing in a single formulary so that we use the same drugs across the 3 different hospitals so that you can have one electronic system that does the same job. That's a complete transformation in the way we work, and it means we can make lots and lots of other savings and efficiencies as well as improvements. So absolutely yes.
Thank you, Frankie. That's really helpful. Now, Ian and Andrew, or indeed Tony, anything you want to add? And particularly on finances. We'll come to Jason on the money, right?
Yeah, Jason Hollidge, Director of Commissioning Finance. This is fantastic because this sets out the what and what the ask is for the capital programme over the next few years. I suppose what we need to do as a system now is really understand the how, and how do we afford this within our restricted capital budgets that we have over the next few years. So we've been allocated a 3-year capital settlement that ends in 24-25. We've got circa £80 million for the next 2 years, but 40 million of that is already committed against RAC and diagnostic programmes. So the 40 million that remains, we need to prioritise some of these items in conjunction with clinical equipment, in conjunction with estates, in conjunction with other digital projects. So there's a real prioritisation piece that now needs to happen off the back of this. But this is a great starting point, and we just need to put it all in the mix and then come out with the answer of what we're going to do in the next few years.
That's very helpful, Jason. Thank you. Any other comments, Ian? Anything you want to add?
I just think digital literacy and digital access is a really crucial part of this, as you said, and it's not just the older age, it's right through our patients and citizens, isn't it, that young people that can't access these things. So I think it's important that digital is a key door into health and care, but not the only door, and not that we provide other opportunities. But I think digital literacy will be a key part of the strategy and something we will take forward with all the partners. So.
Thanks, Patricia. Can I just come back on the finance piece? Because so often, through my experience on NHS boards, both in terms of estates capital and IT capital, we've had brilliant strategies that as a board we all sign up to, and yet sadly the funding falls away. So I do think it is a real priority for us to get our minds around the art of the possible, and I use that cautiously because normally we can't get everything we want, but we need to think very carefully about what our priorities are, where we get the best advantage, whether it's what I might refer to as the back office or data sharing amongst the teams, or the front end cautiously optimistic approach to our population being able to access things. Where do we want to spend this money? Because I suspect we won't get everything we need, and the sooner we get our minds around what we can get, and therefore what we should get underway, the sooner we'll see some benefits coming from this.
Just to come back on that in terms of we need to be really clever in the way that we link this digital strategy in with our other major capital programs, for example, the new hospital programs that we've got going on in the system, the community diagnostic programs. They all link and they all come from the same pot, but there are separate funding streams for each of those as well. So if we're cute in the way we do this, we can get more than if we were going at this individually.
Thank you, Chair. Just, David, to add in response to your question, I think I would describe this more as a plan. I think you're right in terms of the risks around being able to afford it. I think what I would say is that this is the first time, in my experience here, that we've connected this together and we've reached a consensus. So we've had the whole digital community from across the system sitting together. We don't agree on everything. Some trusts might want, or providers might want, a slightly different system for a particular clinical pathway than the others, but there is a national direction of travel. It's called convergence, is the term that they use, and that's what we're looking at where it's practical, possible to do so. So I think on this one, there are some gaps and you can tell it's in there, but I think it's not just about seeking new money. So it's when some of the existing systems come to end of life and they need to be replaced, we would then want to be making those decisions in line with the agreed plan. So I think over a period of time, we will gradually converge towards more standardised infrastructure, as Frankie talked about, EPR being the most notable example, shared care record, patient portal, and so on. If we had 100 million of additional capital, we'd do it quicker. But I think, bear in mind where we are and the amount of time it takes and the kind of lead time of these projects. This is not an overnight solution. I think, James, that was your point, wasn't it? This will take some time, but I look forward to looking back in 3 or 4 years' time, hopefully we've made some good progress.
Yeah, I'm just thinking about partners who aren't part of this, but who we will want to bring on. So in terms of our spec and our ambition, we should share it, because I'm not sure that the district councils are involved with this yet, but as the housing authorities, I'm sure that they have expressed in the ICP an ambition to be part of this. So I think even while we're waiting for the money, if we're clear in what the architecture of our what our framework architecture will look like, then when they're making purchasing decisions outside of this, they can align themselves with the overall strategy, and so can our partners in the private sector and the voluntary sector as well. So I think it's really important that we're clear about what those objectives are so that we can include them as we move forward.
Thank you very much indeed. I mean, we identified this as a really big opportunity, but also a pressing need for our system some years ago even. And this is parts of this, particularly the acute electronic patient record, are critical to safety. And I think we just need to keep that in mind all the way through. Safety and quality really have to be at the heart of this. Thank you. We're now going to move on to the financial report. I thought a really useful high-level summary, very clear presentation in those slides. So thank you to Jason and Stephen on that. Tony, thank you for joining us for that discussion. Jason, anything you want to add to the finance report?
I'll keep it really brief. So the ICB as a statutory organisation is reporting a break-even year-to-date for October position, and also a full year forecast outturn break-even position. There's a significant number of pressures that are being offset by non-recurrent items in year. That leads to a significant challenge for us moving into the new financial year and our planning for that new financial year. In terms of the health system, so the ICS health forecast outturn, that's also at a break-even position for month 7. But the year-to-date position is showing a significant deficit of 7.6 million, and there's currently work ongoing to look at the risk around the full year forecast outturn. And why I mentioned that was because included in the papers is the protocol for changing the year-end forecast for individual organisations and systems, and there's significant impacts both to the system but also individual organisations of changing that forecast. That's really, I just wanted to highlight that. Not go into it in too much detail unless there's any specific questions.
Thank you, Patricia. So in the Finance Committee, we look under the hood of these high-level figures. And as you maybe have read later on in the committee report, we've said we're not assured at this point in time we'll break even. We'll have our meeting next week to look under the hood of month 7. And this is really the quarter in the year we either come clean, we're not going to make it, or we are. So that it is tight, risks are understood. And the protocol is an interesting new feature in that. Hopefully it will lead to good partnership working and understanding where we are, and certain partners need to help each other. But as Jason said, there are some stress points already clear in the year-to-date position, and it will unfold in the months ahead. So thanks.
Thank you very much, Hein. Any, if we can keep them brief, but any comments or questions on Jason's report? Okay, thank you. I mean, I'm really grateful to Jason and Stephen and to Hein on the Finance Committee. I think the work that's been done bringing the finance community together across the whole system is really impressive. It gives us a good foundation to build on in our first year as a statutory integrated care board, but a lot of work to do. Thank you. Karen, the board assurance framework.
Thank you, Chair. This is the usual board assurance framework, which sets out the key risks for the board currently. I just wanted to draw the board's attention to 3 new risks that have been added since you've last reviewed the framework. That is on transition and delegation of primary care services, discharge from inpatient settings and potential industrial action. All the risk owners are in the meeting, so we're able to go through any more detail that the board requires, and work is ongoing with regard to our risk work quite regularly at our executive management team. So I'll leave it there and open up to any questions. Thank you.
Thank you, Karen. Questions or comments on that? I know the team's doing huge, I mean, this is part of the everyday conversation, isn't it, on almost everything? We can all see the red boxes. Okay. Right, we now come to the reports from our committees. These are really for information, but for committee chairs to highlight any particular points. Hein, I think, has already done that in relation to finances. Kathy, I don't think there's anything from you, is there, today? James, on primary care, I don't think there was anything you wanted to highlight. Hilary, ditto. Don't think. Or was there something?
No, we met last week, so you don't have a written report, but we are looking at adjusting the timing of the meetings so that we can get that to you.
You can get into the rhythm of, yeah.
Yeah, the one thing that we talked a little bit about is about the importance of smoking cessation in terms of improving our outcomes and our population health and our use of health services.
Just on that, with my public health hat on, that is certainly one of the priorities of public health for Norfolk, definitely.
I just wonder whether it's worth touching upon the data discussion that we had at that meeting, where we were looking at the risk around data, and there was.
If you want to make just a brief comment on that.
Yeah, and it was more around that we identified a broader risk than that, which is just people getting access to our data and using it in a way that we wouldn't wish to. We were really coming back to the debate around shared data and any blockages that sat in the system to enable partners to share data. And so I think it's worth just raising here to say that although there is some legislation which probably slows that process, we were also looking for a little bit more cooperation across some of the partners, or a little bit more willingness, I suppose, to share data that would allow us to bring together that patient safety issue, which says that we have access to the right data at the right time.
Thank you, David. I think that's really important. And this issue of information governance and who has permission to access what, those, as I recall, a lot of those rules and barriers, safeguards, whatever, were lifted during COVID to enable people to make the best possible decisions about patients quickly. They've been put back in place, I think. Now, those are clearly issues way beyond one system. They might indeed be issues for my reviews separately. But I think it would be very helpful, given that you were also raising wider issues about simply cooperation between different parts of the system, if our executive colleague could take that away, have a look at it, and you can work out the appropriate point, but bring it back, possibly through one of the committees, to this board. I think wherever there are barriers that we can do something about, we've got to do that. We've got to change it fast. And where there are barriers that we need national action on, then we need to highlight those and raise them. So, and this is so important. We need to do it fairly quickly. Ian.
Because I'll take that away, Chair, and come back. It's under my remit. So, thank you.
We now come to questions from the public. I think the simplest thing, Karen, would you mind just guiding us through that? It's going to take me a minute to get to the right page in my pack.
Thank you, Chair. So we have received 6 questions in advance of the meeting. 2 came in earlier in the week, so we do have answers for those, and I'll turn in a moment to relevant people who will talk us through them. The remaining 4 came in last night, so we haven't had an opportunity yet to do a thorough answer on those. However, they will be on the website during the next week for not only everyone in the meeting, but also the general public to be able to review the question and the answer. So the first question that we've received in advance is set out here, so you can read it on the screen. But I'd like to turn to Emma Ratzer, who's going to be able to help us with this one. Thank you.
Thank you very much. Yes, I have been working with Norfolk Community Advice Network on this kind of very problem, really. And I did liaise with the staff there prior to their recent statement of emergency, which they published, and they had their first emergency meeting back on the 9th of November, where 140 people attended, plus some local MPs. So they've got lots of people around the table who are up and willing to make some changes, I think, across the system, which I think will be the first point. They've got their next meeting on the 25th of January. I'll continue in my role with the Assembly to support the work that they're doing and help bring in, because I think one of the roles of the Assembly Chair being at this table is that I can bring in all of you really important people that can access networks and individuals that may or may not be able to make some differences and remove some barriers, which I think will be really helpful. But I absolutely agree that the current contract, as with a lot of things at the moment, doesn't support the numbers, the increases that people are seeing around cost of living. So one of the things I will do is bring back to the board next time after their meeting on the 25th is some of that research about what other people are doing in other areas, so that we can see if we can learn anything, but get a proper understanding about what our figures are in terms of the increases on cost of living and the emergency statements that have gone out, the people in the system that are willing to help remove barriers and identify some work that we can actually do and bring back some recommendations to the board. I'm conscious I need to work closely to Norfolk County Council because it's their contract. So it needs to be something that is aligned with them as well. Yeah, the Assembly is working closely on this one. Thank you.
Thank you very much. I'm not sure if the member of the public who raised that is actually here at the meeting. I think not. I seem reading. I mean, I did read this earlier, but I think it's come from Age UK Norwich, hasn't it?
I know where it's come from,
okay.
Patricia, so I can follow that up.
But not
Thank you.
Okay. Thank you very much indeed, Emma. And then our next question is slide 3, where we are, is the MSK musculoskeletal. Yes. And just on this one, and I'll come to you in a minute, Frankie, but I did just want to take the opportunity to say thank you to the physiotherapist, the occupational therapist, and the consultant rheumatologist who have clearly been beavering away for quite some months on actually how we could better support people with fibromyalgia, so which is an extremely painful condition, I believe. Frankie.
Thank you, Patricia. And yes, I'd like to extend my thanks for this question as well. So we set up a musculoskeletal steering group some months ago, which has led a redesign of our entire service. 2 clinicians from the Norfolk and Norwich and one of the very experienced rheumatology specialist nurses from the Queen Elizabeth have actually been a part of that group. But of course, we couldn't have everybody on it. Otherwise, we probably wouldn't make any recommendations. We'd still be talking about it. But I am delighted to confirm that that piece of work is now complete. So the service redesign is now complete. And we've just been joined by a new senior programme manager who started at the start of this month in November, who's going to be tasked with implementing these changes and overseeing moving forward with lots and lots of areas of transformation. Now, we didn't specifically talk about fibromyalgia during this service redesign, because many of the issues that people with affected by fibromyalgia have are actually quite common to multiple different groups. For example, difficulties accessing the service, bouncing between specialties. That's unfortunately quite common in lots of musculoskeletal problems rather than just fibromyalgia. But actually, in response to this question, we're going to put this questioner in touch, because actually it does sound as though they've done some rather interesting pre-work and thinking about that to see if we can build it into the service. So we're going to give a rather fuller answer on the website and specifically pick up with this physio, because we'd like to use their ideas as well. So thank you for that.
Great. Thank you very much, Frankie. And I think that does illustrate, that actually if the more people working within the health and care services or using health and care services actually do feel able just to raise things directly with us, we can sometimes short circuit what can be quite a lengthy process of getting a question or an idea to the right person to do something about it. So in that spirit, we haven't had any questions emailed to us during the meeting, but I'm just wondering whether I'm sorry, this is not a particularly, because this is a formal council chamber, I can only really see heads of people who are sitting and listening to the meeting, but I'm just wondering whether any of our friends and colleagues, observers who are at the meeting would like to ask a question before we end. Doesn't look like it. All right. Well, thank you again for being with us, and we would certainly welcome your feedback on the meeting afterwards. Karen.
I wonder if it would be worth just very quickly just going through the remaining slides so people online can just pause and read.
Okay, we can
at their own time. What the other questions.
Will they be added to the website?
And they'll also be added to the website alongside the answer in due course. Okay. So maybe we just do slide 6.
Yeah. There was a question about pharmacies not being open. Question here about community hospitals in Great Yarmouth and Waveney, and particularly Halesworth. And Cutler's Hill surgery. So
they came in last night, so they will be put in full on the website, so we can probably take that down then. Thank you.
Them up, Alex. And I think just recognising that those were important and detailed questions that came in last night, where people are able to get questions in advance, it makes it much easier for us to make sure we can give a detailed and completely up-to-date answer at the meeting. Right. Thank you very much to everybody who has asked and answered questions and will answer those remaining ones. Is there any other business anyone wants to raise?
Just to note the dates.
Ah, yes, we need to note the dates. So the next meeting on the 24th of January. Karen, do we not have a meeting in March?
Yes, we do. Right. So I think that might have just got missed.
It got missed off the list, I think, and I didn't spot it in time.
No, neither did I.
Okay,
so we'll get that rectified.
We can correct that and make sure everybody has it and it's on the website. Good. Well, can I thank you all very much indeed. Thanks to those colleagues and observers who've been sitting in, and to those who've been watching online. And for board members, we will now take a 15-minute break and then reassemble at 3:45 for the second half of our meeting, which is the in-private meeting. But I thought I'd put that on. Thank you all very much indeed, and thank you to our tech colleagues who have coped brilliantly and given us support. Thank you all.